Good evening, everyone. We welcome you all to OrthoTV online in association with Pulse Pharmaceuticals, the makers of Bakbone and Deksel. To introduce today's speakers and topic, I hand over to Dr. Harsh Chaturvedi.
This meeting is being recorded.
Thank you so much, Dr. Bijlani, and a very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi, welcoming you on the behalf of Pulse Pharmaceuticals, Hyderabad, to a very exciting evening to debate on the first and foremost on the utility of the FRAX tool, and then subsequently on the management of on surgical challenges in osteoporotic fractures. For this tete-a-tete session today, which is a second in the series, the first one we have had on last Saturday, we have the pleasure of having Dr. Vikas Agashe with us, who is a consultant orthopedic surgeon at PD Hinduja Hospital, Mumbai. And Dr. Agashe has been, as you all are aware, a faculty at various national and international conferences over the years, and his special interests are in trauma, non-unions, infections, metabolic diseases, and especially osteoporosis. Ladies and gentlemen, today Dr. Agashe will be sharing his views, his thoughts on the FRAX score and its usefulness, and also on its limitations. We will also request him to dwell, if possible, briefly on the emerging risk factors, which include homocysteine, iron deficiency, the cardiovascular diseases, and many more. I certainly also look forward to having his views on especially FRAX, because FRAX gives us a probability of a fracture over a period of 10 years. I don't know, and I'm not very sure how accurate it is in terms of false positives and false negatives over a shorter term, let's say 2 years or 3 years. Also, probably somewhere he may like to indicate if the FRAX score needs to be repeated more frequently in patients who are immunocompromised, HIV patients, and that kind of a population. Sir, very warm welcome to you, and we are very keen to learn from you and on the various aspects of the FRAX tool, and especially its relevance in a country like ours, where we have multitude of people, and DEXA is always not possible everywhere. So probably it has a special place for our population. Also, ladies and gentlemen, in today's program, we have the pleasure of listening to Dr. Sushrut Babhulkar. Dr. Babhulkar needs no introduction. He is a trauma and a joint replacement surgeon who is involved with the Sushrut Institute of Medical Sciences at Nagpur as a director. And Dr. Babhulkar, after completing his medical education in India, he has received advanced trainings in US and UK. He has been a keynote speaker at various international and national conferences, including OTA at Washington and Beijing. And I must admit here, to those who do not know, he's a very keen researcher and a very avid publisher, because I was looking at certain of the works he has done. He has numerous publications in various peer-reviewed international and national journals. So, and he has also been contributing vastly to the humanitarian efforts of various non-governmental organizations. With these words, I welcome Dr. Babhulkar to this program, and he'll be sharing his experience with challenges in osteoporosis-related fractures. Before we start this academic session, as we have called it tete-a-tete, I would like to briefly, introduce my company, which is Pulse Pharmaceuticals, as I mentioned at the beginning of the program, based at Hyderabad. And ladies and gentlemen, it's a very proud moment for me, because the company, which was started in 1997, is celebrating its silver jubilee. At Pulse, we firmly believe in researching and developing innovative products which address the pharmacokinetic or pharmacodynamic limitations of various molecules. Indeed, we have a very patient-centric approach, I must admit, to our research and development program, and this very well reflects in our flagship brand, which is Deksel, which incidentally also is one and the only functionalized nano vitamin D3 formulation across the globe. And keeping our view focused because of today's engagement on metabolic bone diseases and other musculoskeletal conditions, we have developed and introduced certain other formulations which include extra calamity, which addresses the osteoporosis, also taking care of homocysteine as a risk factor. We have for back pain, Backwill, and a very recent introduction for osteoarthritic population in KneeFlex. Our organization, ladies and gentlemen, is manned by 1,500 personnel supporting various functions, and at the R&D and the manufacturing facilities, which are spread across the country, and they cater to the global needs of the ailing masses. With these words, I would also like to mention that at Pulse, we strive to make cost-effective therapies available across the globe. And with these words, I welcome you again to this program, and I request Dr. Sushrut Babhulkar to take the program forward. It is over to you, Dr. Babhulkar.
Thank you very much, Harsh. I really appreciate the efforts Pulse Pharma is taking to bring in and share medical knowledge all across us orthopedic surgeons. We orthopedic surgeons have been dealing with lots of issues concerning osteoporosis treatment and surgical management of osteoporosis. It has always confused us how to treat our patients, how to assess them to begin with, and then how to treat them. I have been accompanied by very able, very well known we all know because of his depth and keenness to share his knowledge, Vikas Agashe sir. FRAX has been a tool which came into vogue as a research tool from Sheffield. I know this tool personally well because that point in time with Professor John Kennis, my own brother-in-law, Dr. Ketan Pandey was working, who's in Brunei now. So I have had opportunity to discuss how they were developing this tool and how they came to a conclusion that this should be internationally adopted. With some debate which came in, they came up with the Indian version of it, which is available online. To me, I use FRAX tool very regularly, and after Vikas sir's talk and brief, we will talk about this in more details as to how we as practical orthopedic surgeons can use this tool effectively and more effectively to treat the patients who are symptomatic because of osteoporosis, to treat those patients whom we operate surgically and to avoid subsequent fractures. Let's hear it from the big boss, Dr. Vikas Agashe sir. Over to you. Please share us your thoughts on FRAX. Thank you.
Good evening, Sushrut. Thanks a lot for a very flattering introduction. Hello, Dr. Harsh and all friends from Pulse Pharmaceutical at the moment, at the outset. Thanks a lot for creating this platform to discuss something which is hardly ever discussed. I mean, we hardly ever discuss FRAX. So let me come to the topic itself. Revisiting FRAX score. Is it a waste of time or it is useful? So let's start with definition of osteoporosis. Does this definition help us in assessment of risk for future low trauma fractures or any other mathematical calculation, whether that can help us in assessment of future fracture risk? We all know that we are most concerned about the future fracture risk. And can these help us in deciding a threshold for initiating pharmacological treatment for osteoporosis as well as assessing the response? Now, for years together, since 1885, when Palmer first described osteoporosis as a disease of elderly with fragility fractures and their complications. So more than 100 years, we used to diagnose osteoporosis after fragility fractures, and only after these weak bones would, say, in vertebra collapse or ends of bone develop fractures, which are very commonly treated by all of us, or there is a gradual loss of height. Over a period of 10 years, elderly lady would lose significant height and you would not recognize her after some time. So people knew that these fragility fractures are caused by osteoporosis, and they were defined as fall from standing height or less than standing height. Over a period of time, people realized that it is no point in diagnosing osteoporosis only after fractures have developed. We need to pick them up before fractures develop, and we need to treat them before these fractures develop. The bone strength needs to improve well before chances of fracture develop. It was well known that bones weaken without producing any symptoms. And that is why it was called silent thief, or I call it the chupa Rustum. So for any silent thief, we need to pick up using CID, and therefore we need to define it well. We need to detect it properly. We need to prevent by appropriate management, and we need to treat by appropriate medicines or surgical treatment. With that in mind, the definition of osteoporosis was changed somewhere around 90 or 92, essentially to pick up at-risk individuals and do epidemiological surveys. So the diagnosis, rather definition, was changed to a condition, a metabolic bone disease with low bone mass, microarchitectural deterioration of the skeleton, leading to increased fracture risk. And we have been bombarded with this definition again and again in the last 30 years. And BMD measurements gained significant importance. Generally, it was considered that T-score of minus 2.5 is osteoporosis. However, it was also realized that with poor bone density, probability of major fractures increase, and the fracture probability also increased with age. Now, there are some drawbacks of DEXA. First and foremost, it's not freely available in our country or in many, many areas of the world. Secondly, no machine can pick up why bones become weak. So the reduction, destruction may be because of disease or osteomalacia or several things. And therefore, it is a diagnosis of exclusion. And therefore, if you consider DEXA as a threshold for treatment, then you would possibly treat all these conditions where anti-osteoporotic treatment will not be useful. So it's a diagnosis of exclusion, even if you use DEXA machine. It was soon realized that most fractures occur in individuals with BMD T-scores above the threshold level, above 2.5, better than 2.5. So people realize that there are many thieves apart from low bone mass, which weaken the bone and which are clinical risk factors. Then people realize that WHO had changed the definition not as a threshold of treatment, but to pick up at-risk individuals and do epidemiological surveys. So we started off with the threshold for treatment with clinical background. Then we went to DEXA. And now again, people have realized that we need to combine these other thieves or clinical risk factors. And therefore, this tool, what is called fracture risk assessment tool, was introduced. So essentially, I would very strongly suggest that you read this chapter, Fracture Risk Assessment, Development of Application of FRAX, in this chapter. So many clinical risk factors were introduced. This website was launched, as Dr. Sushrut said, long ago, almost 12, 14 years ago. And today, more than 200,000 individuals use these calculations every month. It is available in number of formats and also included in several guidelines. So let us consider what is FRAX. The outcome of FRAX essentially is a 10-year probability of a major fracture, that is hip fracture, clinical spine, humerus, so on and so forth. And also it considers 10-year probability of hip fracture. And if these probabilities are high, then it is considered as a threshold for treatment. It is a matter to worry, need to start with the treatment. Now, fracture risk. This instrument considers various things. One is age, second is body mass index, and third, various risk factors which are well recognized and independent contributors to fracture risk. Now, what are these factors? There are 12 factors. Initially, 9 factors were introduced, and later on, 10th, 11th, and 12th was introduced. So, age, bone mineral density, BMI, prior fragility fracture, use of oral glucocorticoids, parental history of fracture, current smoking, alcohol intake, and rheumatoid arthritis. Alcohol was not defined then. Then secondary osteoporosis, like insulin-dependent diabetes, osteogenesis imperfecta in adults, hypothyroidism, hypogonadism, menopausal, premature menopause, chronic malnutrition, very important, and chronic liver disease. Added was alcohol 3 units per day, and the optional thing was femoral neck density. Now, this fracture probability, why should it consider age? Basically, because there is always a risk of death. So, if a person dies, there is no question of a fracture. So, in fact, the fracture risk goes on decreasing with age in some cases. And there is a significant difference in fracture probability in various countries. That is dependent on the longevity of the patient. For example, if the longevity is high, then the fracture risk is more because they're going to live and have a fracture. While if the longevity is less, then they're going to have less fracture because there is less chance of developing a fracture. Now, this is how the tool looks on the net. Various countries are developed by represented by their flags, and you can see various factors are put here: sex, weight, so on and so forth. The BMI is calculated from height and weight. Femoral neck BMD is optional. So suppose I say that at my age, there are no risk factors, then major osteoporotic fractures, chances of major osteoporotic fractures are just 3.2% over a period of 10 years. So I'm quite safe. On the other hand, if one has, for my age, there is a female patient with low weight. See, here I have put in weight as 80, Here, there's a female patient of my age with weight of only 45. But again, no comorbidities, no risk factors. Then the chances of major osteoporotic fractures are 8.9 as compared to 3.2, and hip fractures is 4.3. So increase significantly. What happens if there are comorbidities? So again, for my age and my weight, if somebody has a history of previous fracture, parents had fracture, he's on glucocorticoids, then the major osteoporotic fractures are likely to happen in 19% of cases and hip fractures in 10% cases. But the same, with same comorbidities, you consider females with low weight of 45, then major osteoporotic fractures in 10 years, the chances of developing these fractures is as high as 53%. And these are extremely important things. So finally, can this tool be used as an interventional threshold? In the sense, this is the percentage and you need to start treatment. What people used to do with Deksel, can you start treatment based only on these FRAX score? There are two commonly used IT or interventional threshold, intervention threshold. Age-based is UK, India also follows that, and there's a fixed thing. If there's a possibility of major fracture of 20% or hip fracture of 3% in 10 years, then one has to start, or it indicates that one should start anti-osteoporotic treatment. Now, has it been validated involving large groups? Yes. So there are several studies. I just quote one, 10 lakh or 1 million members between 50 and 90 years with a 5-year follow-up were checked, and prediction was almost 81% for hip fracture and 71% for a major osteoporotic fracture. So this was very well validated by this study. This was a prospective study. There was also a retrospective study where FRAX, where prediction for high-risk fracture was associated with osteoporosis, proving FRAX as an efficient predictor. So this retrospective study also suggested that FRAX is extremely useful. Based on all this, WHO has suggested a strategy of clinical risk factors. If the fracture probability is high, then there is no need to do bone densitometry, just start treating. If it is intermediate, then one has to do a BMD, reassess probability based on BMD and clinical markers. If it is high, treat. If it is low, need not treat. And if it is low, then you, of course, wait and watch. Currently, is available in 65 countries. There are 10 Asian countries which use FRAX score. There is a significant difference in the way people use it, either age-based or a fixed criteria. Coming to India, Indian scene, it was developed in 2013. It is age-dependent, related to major osteoporotic fracture of 2.53% at 50 and 17% at 75. That means somebody who is 75 years old and possibility of fracture or probability of major osteoporotic fracture is 17%, then one should initiate treatment. Again, there have been Indian studies which have validated this. Another one, FRAX-based osteoporotic treatment guidelines for research, poor settings in India. And after using it on about 300 patients, they realized that BMD testing to initiate treatment was required only in 32% patients. So almost 70% they could decide based on FRAX that patient need not be treated. Of course, there are some limitations. One is it underestimates the fracture risk in patients with rapid bone loss. Secondly, it's not very useful in patients who are taking treatment. It is most useful in patients who are initiating or before initiating treatment. Generally, it cannot be used as a follow-up tool and cannot give you guideline for stopping treatment. However, it is useful. It is again not very useful for patients whom treatment is clearly indicated. There is no point in using it for a patient who has got multiple fractures. Number second is vitamin D levels are not considered. And in our country, vitamin D deficiency is very common. And unfortunately, those levels are not considered. And again, as Dr. Harsh said, homocysteine levels are also not considered. So to take home, it is useful. There is no doubt that it is useful. It's a great starting point for assessing future fracture risk. And in a country like ours, where BMDs are not freely available, this is an extremely useful tool. It is very useful in guiding treatment decisions for individual patients. And finally, it is for you and me to decide, check the clinical risk factors, and then decide whether this patient needs treatment or does not need treatment. Now, as I said, it's pretty easy to use, and many experts consider it as its drawback. This is too simple. So many risk factors are not included. So this simplicity itself is considered as a drawback by some experts. So friends, this is all about FRAX. Over to you, Sushrut. Thanks a lot.
Thank you, sir. That was excellent and very crispy brief on FRAX. But Vikas sir, do you think FRAX can replace BMD? That's my first question to you.
I personally feel that it will not replace BMD. BMD is an integral part of management of osteoporosis. Again, these are complementary things. BMD would be useful if FRAX score decides that this patient has a significant risk of fracture. Then BMD would come in. Having said this, there would be many cases where the fracture risk is low, and then you need not do BMD.
Sure. For my general physicians who are attending and my orthopedic surgeon colleagues, bone mineral density by DEXA method takes into consideration various regions. So it takes into consideration spine bone density, hip bone density, and also upper extremity. So we have to order where we want to look at so that cumulatively the reporting comes to us for the entire skeleton, or otherwise typically DEXA stations or DEXA centers will give you only spine and hip, and they would negate distal radius, or sometimes they would give only distal radius and spine and negate hip. So you have to specify. That's number 1 point. Number 2 is I would elaborate a little more on FRAX and how I employ it in my patients. FRAX is a questionnaire. You can take a printout of that. You can ask your patients to jot down what they feel. So by the time my patient is waiting for his or her turn to come for DEXA, what I ask my center guys is give them this questionnaire. So by the time my patient is ready with the DEXA report, they also have their FRAX assessment done too. And cumulatively, looking at the BMD report and FRAX report, then I start treatment to my patients. So that's the best case scenario. Most of the centers, especially in periphery where DEXA is not available, I completely agree with Vikas sir. FRAX is the tool to go. FRAX is the way to go. And that brings us to the next question, Vikas sir. How much do you believe in the ultrasound calcaneal studies that was done as maybe a marketing strategy, maybe as a screening strategy? What's your belief and thought on that, Vikas sir?
I think you mentioned it, marketing strategy. It came in a big way, very big way. So many companies started holding camps for doing this ultrasound, which at best is not very accurate, but yes, it does give us some guidelines. It can possibly tell us whether this patient needs further investigations or not. However, What actually happened was, based on that, people started giving pharmacological treatment, and it became a very, very risky affair. You can use it as a survey, but you cannot use it as a threshold for starting treatment.
I agree, sir. I completely agree. And with this, let's discuss a little more about FRAX. You made a passing reference that FRAX has been criticized lately. Of course, FRAX India is available. So you go on the website and you punch in specifically for India, and that is available and that one can use. But FRAX needs readjustments. So if there is a recent fracture, FRAX gets deterred from its path. If the patient is on some medications, especially steroids, FRAX gets deterred. So do you think we as general orthopedic surgeons should consider these readjustments of FRAX, or should we be just continuing FRAX India that's available on the website and just follow the path so that at least we can implement some treatment, because we as orthopedic surgeons are the first doctor community to probably experience osteoporotic patients coming to us rather than endocrinologists or physicians. What do you say, sir?
I agree with you. I mean, this is a good tool. It has its drawbacks, but it helps us to, as you rightly said, they come to us first. They come to us with intertrochanteric fractures, spine fractures, so on and so forth. And we need to initiate treatment. And even in places where BMD is not available, FRAX would definitely help us to initiate treatment. And I would say that we need to go with whatever it is available. Of course, when you think of, it is said, think global, but act local. So globally, or at least in India, at a national level, we need to conduct long-term surveys of a large population. Like I quoted a study with 10 lakh people. We need, as Indians, we need to conduct such studies. Without that, it cannot be validated in our country. But here we need to act locally and we follow whatever we have.
Completely agree. And I'm going to brush up on this. Another very important clinical issue is that if the patient is asymptomatic, and that's the point when they will go to a physician or an endocrinologist, and if they prescribe some medicines, because the patient is asymptomatic, they won't take it. But by the time they come to an orthopedic surgeon, yes, probably with a fracture, correct, or with a back pain which is completely intolerable, and we diagnose them osteoporosis, and because they are already in clinically significant disability and pain, they will accept the therapy more effectively, more readily.
I totally agree with you. Our impact is much more than a physician's impact.
Absolutely. So that brings especially us to another point, that we need to educate our own colleagues more and better on this aspect, which is a silent killer in the society today. Right.
Absolutely. Totally agree with you.
Amino acids, sir. Can you throw some light on significance of amino acids, detecting them, its correlation with the entire therapy of osteoporosis?
Okay. I will just share a small presentation.
Sure.
Can you see my presentation? No?
No, can't see. Now it is started. We are able to see your screen, but start the presentation. Exit करा sir screen.
Okay.
तुमचं presentation on करा आणि मग परत share करा.
केलंय मी. Now?
Yeah, now you're on.
Okay.
Slide show kara. Yeah.
So as you said, there's some amino acids which are useful as well as treatment of osteoporosis is concerned, or possibly causative factors. And one of them is homocysteine. So it is an amino acid, and we have long ago studied all this role of folic acid and pyridoxine and so on and so forth. So hyperhomocysteinemia is considered to be a significant risk factor. It is commonly because of deficiency of vitamin B12, folic acid and pyridoxine, chronic alcohol consumption, and a lot of studies have been done. This more than 18,000, I'll just quote this paper where they had studied more than 18,000 men and women, first in 92-93, and they were followed and checked after 5 years. And they realized that increased levels of homocysteine were, or people who had low levels of homocysteine over a period of 5 years had better physical and mental health. The levels normally are around 11 to 15 micromoles per this normal, while more than 100 would be a disorder called homocysteinuria, and 30 to 100 are considered to be moderately high. It has several problems, cardiovascular system, neurological effects, as well as bone tissue. There is increased fracture risk in elderly patients. It damages endothelial cells and increases thrombus formation. And the downside is it does not affect bone density. So you think that the BMD is good, but actually patient has weak bones because it affects collagen links. So I'll just go through this. So can treatment reduce the chances of fracture and levels of homocysteine and chances of fracture? This was a study published some time back where they checked the prevalence of hypercholecystemia in Indian doctors, and surprisingly, out of these 1,000 doctors, almost 90% were found to have hypercholecystemia. What is the effect on after treatment of in at-risk individuals? So this was a double-blind prospective study, more than 550 patients, and at 2 years, homocysteine levels were increased. Patients who had increased levels, the risk of fractures. Here you can see 5 milligrams of folate and 1500 milligrams of mecobalamin versus double placebo. So homocysteine levels, when with placebo, levels increase. With treatment, the levels decrease by 30%. The number of hip fractures per 1,000 patient years were 10 and 43. 10 in treated patients and 43 in placebo patients. This was another very large study, almost 3,600 patients. Again, they proved that the risk of fractures is less after treating with these two vitamins. So the most effective treatment is folic acid, B12 and B6. There are some foods which contain this. However, the only natural source of B12 is from animal products. So people who are vegetarian need to have appropriate supplementation on a regular basis. There is a concept called active vitamins and active folate. This is, I will just skip because I don't think we have adequate time for this. All in all, one should remember that homocysteine plays a very major role. High levels of homocysteine play a very major role in bone disease, cardiovascular disease, and neurological disease, and it can be treated appropriately by vitamin supplementation. I think that
you
overall,
absolutely pinned it down, sir. Excellent. So with this brief knowledge, shall I share my thoughts on how we as orthopedic surgeons can handle the osteoporotic fractures? And I am absolutely indebted to Pulse Pharma, good friend Samar Ghosh and Dr. Harsh to bring in this topic and allow me and Vikas sir to share our thoughts on this. We as orthopedic surgeons are fond of Singh and Maini index because that's so obvious once we look at hip x-rays, and it's very obvious based on the trabecular pattern which are seen so obviously, especially with the digital x-rays, and we can easily say that okay, this is osteoporosis. But whether and how we can quantify osteoporosis is what we should do and what we should learn. Just to throw some light, we lost Dr. Singh only last year, who is the originator of Singh and Maini index, which we talk about so very every day. And PS Maini sir and Singh was the one who designed this. Just to throw some light on the general knowledge about fragility fractures is extremely common. 1 in 2 women and 1 in 5 men over age of 50 will suffer it. If you want to tell your patients what is its importance in general health, that's the graph which one should know and which one should tell our patients. The importance of hip fracture is 80% of them, extreme right, the pink column that you see, 80% will be still unable to carry out at least one independent activity of daily living. So that's the impact of hip fracture. And there are lots of these x-rays that we as orthopedic surgeons come across because of our implant failing or implant walking out, because of course, fracture geometry, difficult fracture, but also poor quality of bone which we are dealing with. Even with spine fractures, there is a diminished quality of life. So we are talking of improving our quality of life of patients. Even with distal radius fractures, only 50%, the third column, only 50% will report good functional outcome at the end of 6 months. So millions of fragility fractures are occurring all over, and we all as orthopedic surgeons will have to treat them with some or the other technical advancements. So there are technical challenges that we face. What technical challenges? Impaired ability of osteoporotic bones to hold screws or support implants because of the crushing of cancellous bone with subsequent voids, which do not allow us to reduce the fracture swell. So these are the fractures which can lead to higher risk of failure of these implants. So there are special considerations that we should know. Of course, arthroplasty is replacing the fracture or the bone in question, which will allow early mobilization, and it will be less demanding on technicality. But we also have some implants which have been designed for osteoporotic bones, and we will look at them. As we are going across the plane, intramedullary fixation is preferred to surface implants mostly. And if there is a void, we have good cementing technique, we have better understanding of bone grafts. We will look at some of these examples, and I will quote some examples, the clinical scenarios. Once we know them, once we understand them, you can employ these ideas tomorrow morning in your patients. So hip, shoulder, knee, elbow, such fractures as are seen here are the indications or are the proper indications in presence of osteoporosis for arthroplasty. Apart from these indications, we should try to do bone reconstruction or fracture fixation. So hip hemiarthroplasty or shoulder arthroplasty for typical fractures, comminuted articular zones are the indications for replacements. But fractures away from articular zone in the periarticular area are the fractures which should be fixed so that patients recoup well. We are avoiding major reconstructions, and there are some technical things which are available, some weapons which are in our hand, like fixed angle locking plates, which can bail us out of the situation. We can augment the plating by using certain augmentation techniques. For example, the screws which are hydroxyapatite coated, screws which have wider pitch, screws which have better purchase are the screws which can be used to augment our plate fixation or intramedullary nail fixation. Even DHS, that is so popularly used, can be used along with calcium hydroxyapatite coated, better purchase, wider screws with a better pitch. So these screws are now available for dealing, especially for osteoporotic fractures. Appendicular skeleton or axial skeleton, both are the fractures wherein we need to strategize ourselves. So we have to, because the patient is older, we have to strategize. We have to do minimal invasive surgeries, but effective, well secured fixation is what we want to choose. So intermedullary fixation is more and more preferred. If you want to do a osteoporotic fracture or a comminuted fracture, we have to make sure that your implant which we are using secure the fixation on day one. Otherwise, we are leading for failure or walking out of the surgery. Osteoporosis will lead to a lot of void, lot of defect, which can be seen on plain X-ray, which can be assessed more quantitatively and in a more better way by a CT scan. We can augment by using bone morphogenetic proteins, by using bone grafting techniques, which are available today. So lots of techniques which are like vertebroplasty, wherein you can avoid further nerve compression by using vertebroplasty, instrumentation techniques, and better and effective fixation, so that we can get the patient out of bed and avoid morbidity and mortality of the patients. There are lots of guidelines for rehabilitation also, especially to look at fall prevention, because prevention is better than curing these patients. With this brief theory, let's look at more action. So let's look at this case. So this was a polyarticular young female long-term steroid who came to me with steroids on, DMRDs on. That was a fracture. One side replacement was done already. Other side was fixed by the surgeon, the original surgeon. So this was a good case of fixation. Patient is osteoporotic already because patient is rheumatoid. Surgeon wanted to dynamize, so removed the screw from this level, and implant started failing because of non-union there. So that's the screw which was removed. Implant failed completely because the implant was removed, and that was the point in time 6 months later when the patient landed up with me. So what are my choices in this scenario? The nail distally is still stuck. So my choices is, because the patient is rheumatoid, either use a long stem implant. I used that long stem. The patient was very small, 4 feet 8 inches. So that was the longest 6 millimeter diameter stem which could go in. And again, within 12 days, because of pre-existing osteoporosis at the tip of fracture, which was the tip of the nail, stress riser, patient had another fracture. So my options at this point in time is, again, of course, a longer stem but it won't go in because the patient's bone would not accept that. Clamp on plates, which are called as Menon plates, or use a surface implant to do this. This was 15-20 years back. I chose to use a surface implant. Cerclage wires was used, came to my rescue. I somehow used it. And at this point in time, with my little knowledge then 20 years back, I used vitamin D3 and imported teriparatide 40, which was imported for this patient. And suddenly, with this, patient started throwing bone. And in 12 months, it completely healed. That's 3 years, same patient, huge bone callus formation, good position. So my suggestion to my colleagues, we as orthos, we tend to neglect the underlying metabolic bone disease. So pay attention to that. Though you are dealing with fracture, please try to understand that there is bone and we need to address metabolic bone issue. Another case, mother of an anesthetist, 75 years, AVN of the hip. So patient for AVN required total hip replacement, got it done somewhere else. Post total hip replacement, trivial fall, fracture, it was also fixed somewhere else. And after the fracture was fixed, the patient came to me. So this is how the patient came to me. Rheumatoid, AVN, osteoporosis, failed fracture, failed acetabular cup, loosening of the cup. That's how patient comes to me. Obvious answer, you have to revise everything. So that's how the patient came to me. That's how I revised uncemented total hip, bone grafts, allografts, reconstruction of acetabular cup, a long stem, cerclage wiring. That's how it is. What I want to drive in is watch the length of the stem. It is long stem, but not too long. And it was healing well till the time the patient had another periprosthetic fracture where the tip was ending. The patient is still with me. What do I do? Osteoporosis, difficult situation, 75-year-old lady. That's the fracture. Reduced it well, long plate, surface implant, cerclage wire, proximal screws in the trochanter, cerclage wire in the proximal segment, all along till the lower end femur plate. Cerclage wires are very easy, ways to pass them in a minimal invasive way. We should learn it. It should start throwing callus as soon as we correct the metabolism. That's the picture. That's the picture. So when you have less purchase in bone, either because of implant inside, which was total hip here, poor bone quality, remember cerclage wires passed in a biological way, making sure that you are flush to the bone and not engulfing the sciatic nerve posteriorly or femoral artery medially anteriorly. Find that flush to the bone plane, remain flush to the bone. Cerclage wires are a very effective tool for an additional augmentation to whatever you use, intravertebral nail or a surface implant in these difficult osteoporotic fractures. Let's look at the next case. Fracture at the tip of your AMP or a total hip. In this case, it was a total hip. These kind of fractures with a small twist or turn in the bathroom by the patient. Very, very common. What do we do? Patient has osteoporosis. I started with one side, a long implant. Acute reduction is extremely important. Use a collinear clamp, the one which I showed you. From Eosynthis, it's similar brothers and sister Indian varieties are available everywhere. So that's how you use a long surface implant, adequately fitted, correction of osteoporosis will throw good amount of callus. So use as long as implant, span the entire length of the bone, because you never know, it will fracture at the tip of the implant, whatever you use. So may it be an intramedullary prosthesis or extramedullary plate, try to span the entire length of the bone. Next case, very common fracture. This was a subtrochanteric fracture which was fixed by DHS, not a alendronate kind of a fracture, revised to a, because it was going into non-union, because it was a DHS surface implant, I chose to do an intramedullary implant, not adequate reduction, not good reduction, antegrade nail changed to PFN. So first change was antegrade femur nail, bad choice of implant. I changed it to antegrade femur nail, not good reduction, still in varus, PFN with bone grafting. That's how it was. Patient is rheumatoid. Patient has a bad valgus knee, what you can see in the X-ray on the right. So patient was already on the wait list for getting her knee done. This is what the position was at the tip of your PFN, which was reduced in varus. Patient had another fracture at subcapital level. Screw started backing off. Patient is waiting for TKR. I did the hip first, replaced it because it was anyways rheumatoid hip, rheumatoid knee, replaced the knee, same side. That's how it was looking. Rheumatoid, on drugs, osteoporosis, wash the entire span which is between the tip of hip and the proximal femur. Corona lockdown situation, patient told me that she is having some trouble, fracture, tip of processes, tibial side. Patient was 300 kilometers away from my place. Patient walked in. I did an intramedullary fixation. I did a more better surface implant, a long plate. That's the position. Intramedullary fixation was the only nail, Ender's nail, which I could negotiate here. I could not negotiate a better nail, but I wanted some augmentation to my surface implant, which is the tibial plate. So multiple fractures is extremely common seen. Keep watching end of the implant, post-stress risers, and eventually fracture. So please keep that in mind, especially for polyarticular rheumatoid, especially when you're doing multiple joints in this case. So that's again a very common scenario. As I told you, how do you classify them? So what you need is a long plate all along. Is it okay? Here I chose to do a fibular strut graft, if you can see, which I have placed anterolaterally along with my plate, and I have engulfed fibular strut to throw in more biology at the fracture side. And of course, I have added some iliac corticocancellous grafts as well at the fracture side. I fancy this because fibular strut graft, a long graft, gives me two plane fixation. One plane is the plane of plate, which I'm using, and another plane, which is the plane of fibular strut graft. It gives a biplanar fixation for this complicated osteoporotic fractures. Or otherwise, these days I am using a shorter plate perpendicular to the main plate, which I'm using for osteoporotic fractures. So a double plate, double plane fixation, or intramedullary rod and a surface implant is the way to go for these difficult osteoporotic fractures. So longer plate, top would have been better, graft added for biology. So bone grafting helps, fibular strut is a good option. So to conclude, fractures are extremely common and fractures will be more common because of osteoporosis. Osteoporotic fractures are associated with increased morbidity and mortality. A fracture is common among the strongest risk factors for future fractures. Refracture rate is also very, very high. Majority of patients with fragility fractures are not evaluated or treated for osteoporosis, and it is, as orthopedic surgeons, it is our duty it is our opportunity to take these patients, convince them at least when they are indoor to start on one shot of pharmacological agent. I prefer zoledronic because that's when you can give them when they are indoor and secure their 1 year. Effective treatment are now available. Orthopedic surgeons are usually the treating physician and can take an active role. So my request also to rest of the pharma world is focus on training orthopedic trauma surgeons, because they are the ones who are going to be seeing the patients basically before anyone realizes that patient needs treatment and patient would accept treatment, because they are that point in time undergoing the crisis of pain and the crisis of getting hospitalized because of osteoporotic fractures. Thank you very much.
Fantastic, Sushrut. That was great. A full spectrum of osteoporotic fractures. Just one very important thing I thought you could clarify. There's a fantastic paper by you in Injury about the comminuted intertrochanteric fractures. I'm sure the people who are attending would very much like to know from you about what are your findings and what are your suggestions.
Okay. So
I understand we have hardly any time, but please.
Thank you very much for bringing that up. Unstable trochanter, which is to me today, the idea from the time I published the article has evolved more, in the sense that unstable trochanter is an effect of deficient lateral wall and deficient posterior wall and deficient anteromedial part. So one component, two components, all three together will lead to unstable trochanter. Unstable trochanter in young differs vastly from unstable trochanter in osteoporosis. Unstable trochanter in young must be fixed at all costs. Unstable trochanter in elderly population, which are barely managing to walk with the help of walker, are the only candidates to be considered for reconstruction or arthroplasty. And arthroplasty has to be done after reconstructing the trochanter, otherwise the arthroplasty is amenable to fail. Even if on X-ray it looks good on day one, all the fragments will walk out and float and the arthroplasty will fail. So irrespective of what you are doing, reconstruction by fixation or hemiarthroplasty or total hip or a modular bipolar, reconstruction of trochanter is a must. And we must identify what has led to unstableness by doing CT scan to learn how you can read the X-ray. Once you do 10 CT scans in the initial period, only on a plain X-ray, you can see double shadow will address towards posterior wall. Flying big chunk of lesser trochanter will address towards anteromedial fragment. And a deficient lateral wall is very easy to know on a plain AP and a dead lateral X-ray, because deficient lateral wall is not only on AP. You have to see the deficiency of lateral wall less than 5 millimeter. Globally, it can be anywhere. It can be lateral, it can be anterolateral, it can be posterolateral. So wherever that lateral wall is deficient, you have to address that issue and reconstruct that. So my idea has evolved more, and various ways to tackle them is by my favorite is of course a surcharge wire, because it's more biological. It will still keep most of the muscle attachments to these tiny fragments intact, because you push in more surface implants there, you pass on more screws, you will dissect the muscle and create more avascular fragments, which will throw in less callus. So try to maintain the muscle attachments to these tiny fragments. So cerclage wire, which will gum them up together, and a biological fixation either by an intramedullary, or if it's a bifocal fracture, neck, femur, as well as trochanter fracture, try to reconstruct them by passing multiple screws is my favorite way, sir.
Yeah. Thanks a lot. Fantastic. Fantastic. Do you have time for just one small question?
Yes, sure. Last question, and then we wrap it up.
Yeah.
Give it to Harsh to wrap it up.
So continuing this same thing, will your treatment be different if there is a good stable anterior medial cortices? Both the cortices are coming together, creating a very stable construct and a comminuted lateral wall versus anterior combination, posterior combination, and lateral combination. Would your treatment be different?
Yes, absolutely. Because, okay, so the reduction is the key. In young patients, reduction is the key. All the fragments must be in contact with each other to avoid our primary implant to walk out. So we have to make sure that posteriorly it is closed, the window is closed. It is imperative that the huge chunk of lesser trochanter, which is anteromedially, is gumming up with the main fragment for allowing not to fail our fractures in varus. So that's important. And the cerclage wire technique, which is widely known on YouTube, the cerclage wire, which is distal, takes and engulfs that lesser trochanter fragment and pulls it down. You have to make sure that that fragment is pulled down and is in touch with the head, neck, and shaft fragment. We today don't need to dissect it open. I don't believe that we have to put that long medial calcar plate. I don't believe that, unless until it's a fractured neck of femur in young patient, that calcar plate in comminuted trochanter fracture is required. So if we are talking of comminuted trochanter fracture with a separate floating lesser trochanter, just need to bring it together because of its muscle attachment, because you have pulled it together to the main fragment, it should gum up and fall into place. But primary thing is reduction. Always pay attention to reduction. First, reduce all these comminuted fragments and then make an entry point for your intramedullary nail, which is my favorite in unstable situation. And again, we all used to do intramedullary nail. Then we shifted to DHS, thinking that DHS will allow better ability to reduce these fragments. We have gone back to again better nail designs and understanding of how to reduce them in a biological closed way, back to intramedullary devices for these difficult trochanteric fractures.
Just last question.
Sure.
In a porotic fracture, you would prefer nail with 2 screws, a single screw central, or a blade?
Excellent question. Spiral blade is completely out to me, because it was thought that it is Messiha for osteoporotic fractures, has fallen into disrepute because of way it is failing in osteoporotic fractures. 2 screws is good. Most of our colleagues are used to passing 2 screws. Purchase of 2 screws is not so good, especially in osteoporotic fractures. Comminuted, unstable trochanter, young bones, good trabeculae, 2 screws, way to go. In osteoporotic, trabecular bone loss, bad bone quality, single screw with a broader pitch or a broader width of screws is probably my way to go today. Why? Because easy to do, better purchase, better ability to control, and faster.
Great. Thanks a lot. That was great.
Thank
you very much.
Harsh, over to you. You want to say something?
Yes, sir. First and foremost, I want to express my gratitude and thanks. I'm sure we have audience about 1,100 in number.
That's great.
And all of them will be benefited Uh, the the thoughts which Dr. Babhulkar you have shared from your vast experience, and the tips, and many of the young orthopedic surgeons who are there with us, they are all going to be benefited. And as Dr. Agashe has mentioned, sir, BMD may not be the right reflection many a times, and especially when you have emphasized on the role of homocysteine, where you have very succinctly have brought out that collagen cross-linking is the thing, and therefore we will not get the right reflection by of the risk by just estimating the BMD. It's very pertinent, especially in a country like ours where we suffer from a lot of cardiovascular morbidity. Most of those individuals are bound to be having a very high level of homocysteine. And also the individuals, now we know it's more definitely also involved in the cerebrovascular risk and the incidence. So I don't think, there could have been a better tete-a-tete on the subject.
Can I quickly add something here, Harsh?
Yes.
Just as a passing message to all my fellow colleagues.
Sure, sir, sure.
So it is a cumulative approach of doing FRAX, understanding clinically what the patient is in need of, because I think and I believe that our entire country is deficient in vitamin D and B12. If you do the statistics and start doing the tests. Anna, Vikas sir, what do you say?
Totally agree with you.
So,
totally agree.
FRAX, clinical symptomatology, supplemented by BMD, cumulative approach, should be the way to treat them very effectively, as Vikas sir has so well described in his talk. And of course, as they fall, surgical management will keep on evolving scientifically and technically, and we will keep on discussing that for years to come.
You have made my job very easy, sir. The concluding remarks have come from you, and you have wrapped it up so well that I really don't know what to say except thank you now. But then, having said that, yes, the way Sir Dr. Agashe has emphasized on the need, and especially he's brought out that it's a very validated tool, I see that there is all the more need to take it further, and especially with the multitude of people we have in our country. Probably this is one of the best things which could have happened. I have one last question, sir, if I am permitted. Why cannot I use it subsequent to the treatment, to evaluate the progress of the treatment? I believe the facets will break it down, why it's only in the diagnosis, we can evaluate the, let's say, prognosis and bring in that aspect as well.
No, it can give you prognosis. However, most of the risk factors remain same. Most of the risk factors remain same. And so post-pharmacological treatment, there could be an improvement, but if the risk factors, clinical risk factors have remained same.
Because they are not quantified here, that I take it as a reason, because we are not really estimating and putting in the numbers which are there. Correct. Rather than taking whether yes or no, right?
Correct. It's just yes and no. Just yes and no.
Yes, yeah. And I would just like to inform last week, sir, we had Dr. Kiran Acharya talking to us from Manipal, and he brought in that they are on the verge of completing some work where they are evaluating FRAX and FRAX with Deksel, for prediction. And I just hope that the FRAX tool should be adequate on its own, as you have indicated, for a country like ours. With these words, sir, I thank you so very much, and Dr. Babhulkar also so very much for enlightening us on this subject. And ladies and gentlemen, we'll continue with the series of programs, and we'll be bringing and sharing. We'll have another set of icons sharing their thoughts with you on the subject next week. So thank you very much, ladies and gentlemen. Thank you, Dr. Agashe. Thank you, Dr. Babhulkar. And if I do not thank Dr. Bijlani for giving us this opportunity, I would not be doing my work properly. So thank you, Dr. Bijlani, for giving us this opportunity, and also for stretching it for another 15 minutes.
Hmm.
Thank you, ladies and
Thank you.
gentlemen.
Good night.
Thank you very much. Thank you, Vikas sir. Thanks, Neeraj.
Thank you.